Many people still believe frailty is associated with aging. We used to think it was an inevitable part of growing old. However, that is not true. Frailty is not a natural part of aging. There's more and more research that demonstrates we can avoid frailty. As you age, you can make a choice to avoid frailty and keep yourself functioning independently longer by getting informed and participating in your own health. Basically, you have two choices. You can work to ensure your body functions optimally, or you can sit back and allow Mother Time to slowly chip away at your body and your mind. The challenge, of course, is that sitting back is the antithesis of aging well. Even if you have chronic health conditions, it is possible to exercise, eat well, and get involved. In fact, it's the best way to prevent frailty. When you stop moving, stop exercising your body and your brain, stop socializing, well, the consequences not only shorten your life, they increase suffering. There is a tsunami of boomers heading north of 70. I'm one of them. We're in the pre-frailty stage of our lives. The good news is we're learning a lot through research on how to identify frailty early and intervene sooner. Some of the leading research on frailty is done here in Canada, and what we're learning is changing how doctors practice and what seniors can do to stay well. In order to age well, you need to learn how to avoid frailty. Dr. John Muscedere of the Canadian Frailty Network is committed to fighting frailty. He joins us this week for a conversation that matters on why frailty is the fight of our lives and what we and everyone involved in healthcare can and needs to do about it.
Conversations That Matter is a partner program for the Centre for Dialogue at Simon Fraser University. The production of this program is made possible thanks to the support of the following and viewers like you.
Dr. Muscedere, welcome to Conversations That Matter. Where are we at in our understanding of frailty?
So frailty is, there's increasing knowledge of frailty. For example, there was about 1,200 publications specifically referencing frailty last year. We understand it to be a state of increased vulnerability in people as they age. It's a better marker of vulnerability and poor outcomes than age alone, and it better quantifies biological age versus chronological age. And we all know some people can live into their 80s and are perfectly healthy, whether some people in their 60s have multiple medical problems and aren't doing as well, and so they have different biological ages. And I think frailty intuitively gives you a better understanding of their biological age as opposed to chronological age.
What kind of issues does frailty present to the healthcare system?
Frailty presents huge problems for the healthcare system because so frail patients, for example, if you look at it by sector, most hospitalized elderly patients are frail. Most patients in long-term care homes or residential care are frail, and there's about 1.1 million frail Canadians in Canada at the present time. That's expected to double over the next 10 years if you look at demographic changes. So about a quarter of the people over the age of 65 will be frail. It rises to about over 50% of the people over the age of 85 will be frail.
What's your message to governments then?
The message to governments is that most governments have senior strategies, but I think what we need to do is refocus on and focus on the people that are the most vulnerable. Those are the people that are frail. And in those proactive models of management will probably, do delay the onset of dependence, delay the onset of functional disability and hospitalization. So targeting people that are becoming frail, and looking at proactive models of management will in the long term increase health care, will reduce health care costs, but more importantly, improve health care outcomes.
I can imagine ministers of finance and ministers of health going, okay, just a second, our system's already overtaxed. How do I reallocate resources to this? And how do I know this is going to provide the kind of outcomes that I want?
Well, first of all, it's not, I don't think that the system needs more resources. I think the system needs better targeting of resources to the people that are at the that are the most vulnerable, which tend to be, from an aging point of view, tend to be the people that are frail. And it starts from looking at a community, so people in the community, targeting them, such as the CARES program here, looking at preventive ways ways of preventing from frailty from progressing, to all the way to better end-of-life care for people who have advanced stages of frailty, which we know is a late life or end-of-life phenomena, and actually looking at different models of care, including integrated palliative care, such that their quality of life is improved, and because we really, at that stage, can't do much for their quantity of life.
Yeah, and then we really see expenses pile on when we get into emergent or palliative care.
Where the expenses pile up is people who have had a progressive decline in their health, and their trajectory of life are going downhill, and then they come into contact with acute care institutions. Acute care institutions for those people tend to not be very good, usually exacerbate the underlying problem, and a lot of times people near the end of life undergo expensive interventions which don't increase quantity of life and worsen quality of life. So what we need to do is have better ways of knowing, first of all, the patient's wishes, and knowing who will benefit and not benefit from intensification of care at end of life.
So let's move down the hierarchy of administrative roles in the delivery of healthcare. When you get to healthcare authority administrators, what are you telling them?
What we're telling them is that you can put in place programs that will, over a period of time, reduce the utilization of acute care. So, for example, if we for example, home care. If we change home care from more reactive models of care to more proactive models of care, where we intervene earlier in the patient's trajectory, we a lot of times will stop the utilization of acute care resources, which are the most expensive, which a lot of times don't have the outcomes that we associate with them. Acute care is really good when you have one medical problem, when you have the acute crisis. It's not really good for dealing with people with chronic comorbidities or multiple medical problems, such as people who are frail. Mm-hmm. So and the challenge will be, and you alluded to this earlier on, the challenge will be the reallocation of those resources. It's a challenge, but it is doable. It's sort of, we have to rethink how the healthcare system works, and it looks at innovative models of care. So in utilizing maybe non-healthcare resources to help deal with the increasing number of frail patients. So for example, there's pilot studies looking at paramedics, the firefighters, looking at volunteer resources, all these things, and actually changing it to more community models of care to strict healthcare related problem, because it's not strictly a healthcare problem, it's a community. Aging is part of society, and we need to treat it as such, aging and frailty, not just aging in itself.
Let's jump around the clinicians or the relationship between the primary healthcare provider and the patient for the moment, and go to that of the community. You have mayors and city councils and so on. What are you saying to them that they need to put in place or realign resources so that seniors, especially those in the pre-frailty stage, can prevent or stop the onset of frailty?
And so there's multiple things, and I think municipalities and communities need to be much more involved. So you can think of things anywhere from building regulations to the design of communities and how isolated they are, and also innovative models. For example, there's a model at a university where they have university students staying with people in residential care to decrease social isolation. So there's different models that you can put into place. It's utilizing, for example, the paramedics in their off hours, but those are typically municipally controlled. So you need to bring them into that discussion. It's the design of long-term care homes or residential care homes. How you actually design them, how you may actually make them friendly and environments where the quality of life is where maintenance of quality of life is paramount.
So there's a realignment of thinking as well as resources.
There's a huge realignment of thinking and resources. The healthcare system came into being to address acute single problem deteriorations, and right now it does that really well. And it tends to be monolithic in that point of view. But in order to address care in people who are frail and address the aging population, and all developed societies around the world are dealing with that, we need to really rethink what healthcare, what care is for these people, and that includes improving social care, improves integrated health care, it involves design of our communities going forward. So it's not going to be something that we can do next year. It's not something that we can do in a few years' time, but long-term thinking, I think, is going to be needed to actually address the aging demographic that Canada's facing, and certainly a lot of countries are facing.
We can look at governments, administrators, and local communities and say, you can see why this is a benefit, and they're going to say yes, yes, and it's easy for them to say, okay, go ahead and do that. But for those people who are actually on the ground, what kinds of programs and resources are they going to need to be able to effectively address the issues associated with frailty?
So there's two things that are needed. One is systematic recognition of people who are frail. Recognizing people that are frail or becoming frail or are vulnerable is not as easy as it seems, and putting in place systematic ways that you can identify people that are vulnerable, that are becoming increasing frail is the first thing. The second thing is to have, once you identify somebody who is frail, is to actually have evidence that you can actually, as to how to improve their outcomes. And as part of the Canadian Frailty Network, we're working on both things. One is promoting the systematic identification of frailty, and the second part is funding research that will actually increase the evidence for their care. So you need both things. As a society, the first thing that we need to start is recognizing that not all aging is the same, recognizing that some people who are aging are more vulnerable than others, and start to recognize frailty in its various stages of severity, such that we can start to apply the current evidence to their care.
So in talking to clinicians who already have a very full workload and say to them, okay, now I want you to address frailty in your patients who are pre-frail and or are already frail. You know, it's going to take longer than your normal visit. How do you get that message through to them? What becomes important to them to make them say, yes, I want to embrace this? Because ultimately, they're the ones doing the work.
Absolutely. So there's a couple of things there. First of all, most clinicians want to do the right thing. Second of all, what you want to do, and they're probably already dealing with people that are frail. And third of all, you need to not sell the message, but you want to emphasize the message that intervening earlier or recognizing people that are frail will allow them to deliver better care, which will actually reduce utilization down the line. And then you can also put into place rewards for doing that. So you either, for example, you can put in place the billing codes such to assess for frailty, as the province of British Columbia has done. You can put or just even report cards to say you have this many people that are frail in your practice, they should be receiving these qualities of care, and only 20% of them have received that quality of care. So use the quality improvement models to try to improve care. I think clinicians will do it. I think frailty is under-recognized, and we just need to give them the tools and the evidence to deal with it.
So what do we know about the results? It's still very early days in taking on this whole frailty issue, especially as there's this tsunami of age moving forward. What do we know of the results when people actually embrace the changes into their lives?
If you look at the evidence and what interventions we can do to help reduce frailty, it's exercise, it's nutrition, and all those sort of things. And we know that better, and the other aspect of it is if you recognize frailty, better advanced care planning leads to reductions in healthcare utilization, but also more importantly leads to improvements in satisfaction with the care, both on the part of patients and their care providers.
When we look at the work of Dr. Rockwood and the geriatric assessment tool, how important is that tool? And once we understand that, from there, how important is it that we be able to map where a person is on the frailty scale?
So the nice thing about the geriatric assessment is that actually allows you to develop a care plan from it because it identifies the deficits. So you do two things there. You measure frailty, you become aware of frailty, but you also have an inclination as to things that you can address from a frailty point of view. So that is crucially important. The interesting thing is that a lot of the work on frailty has actually been done in Canada, but some other countries like England are ahead of us in implementing frailty within their healthcare systems. So I think that
what about quality of life? Have we been able to look at people and say, this is the trajectory you were on, but now here you are, and this is how it improves the quality of your life? Are we able to do that, or is it still a little too early to present that evidence?
Well, quality of life is one of those things which I think requires further study, but we know that so increasing functional status as you can with exercise, that's definitely going to improve your quality of life. And, reducing dependence, that definitely improves quality of life. Improving your satisfaction with the care that you receive, or reducing the care or the amount of burden that you perceive that you're putting on your caregivers improves your quality of life. So we know that those type of interventions are really important.
It's not going away, and we have to, I would imagine, be vigilant about our attention to this, because when I look at frailty, I think this is the big lesson we learned from the generation that went before us, those people who far exceeded life expectancy. And what I think we learned from them is that you can't just kick back. You have to remain active. Otherwise, that period of life that didn't exist before for most humans could be painful.
The average life expectancy was in the 50s or early 60s, 3-4 decades ago. So I think when we start to look at that, more people are surviving into late ages with actually very few self-identified functional limitations. But we've also done the other thing. We've increased the number of people who are surviving longer with severely reduced functional limitations, and we actually have not dealt with them very well because, first of all, a lot of them haven't been included in research studies. We don't have great evidence for them, and then we tend to apply acute care models to those peoples which don't tend to work. And if you thought critically, we probably should have started this type of thinking 10, 15 years ago when all those preventive models of care have, at some point, we can only delay death or we can delay disability, but at some point all of us are going to become frail at some point, some for longer periods than others.
What are then the 4 or 5 most important things we can all do to delay the onset of frailty?
Great question. So there's a couple of things. The first one is exercise. We know that staying active into your old as the years go by is incredibly important. Living in a community that facilitates that is really important. Diet is an incredibly important one. Too, having adequate nutrition is important. Looking at utilization of reduction in medication use, polypharmacy. We know that the more medications you are, the more frail you're likely to be, and polypharmacy and frailty are correlated. We're reducing those. Discussing with your healthcare provider about the advanced care planning, really important in case you do run into catastrophic illness. So those are 4 things. Those are probably the major things.
They are the major things, aren't they? And socialization. I also think that plays a very important role.
Oh, thank you for. So social isolation is a determinant of frailty. Keeping socially intact, having social networks is very important. And as society has changed, we become actually more connected to information, but less socially connected. And going forward, building communities that are socially connected or that advance social connectedness is extremely important.
Right now, we know that life expectancy can be 80, 81 years in Canada as an average. If we do all of these things and we pay attention to it, do we have any idea of what the upper limit is of a life well lived?
Well, probably that's open to debate as to how long we can live. But it's actually, we should, I think as a society, that's one thing that we need to rethink. It's not quantity. It's how long we live with quality of life at the end. And that's got to be how we sort of reconceptualize growing old. It's growing old as long as possible with the best quality of life, not the most quantity of life.
Thank you. It's a complex health challenge, one that we face, that we all face. Thank you for doing this.